At Professional Risk Management Services, our medical liability insurance program for psychiatrists and behavioral health group practices, the Psychiatrist Program, is designed to meet your needs throughout the various stages of your career. As a national psychiatry-specific program, a policy with PRMS can cover child and adolescent, forensic, early career, and military psychiatrists, as well as moonlighting residents and fellows, part-time practitioners, and telepsychiatrists. Learn more about how PRMS can protect you.
Good evening, everyone, and welcome back to our podcast series by WPS. Mary, I'm Mikadze. I'm a third-year psychiatry resident, and today we're joined by Dr. Israel, who is a board-certified psychiatrist and currently runs his private practice, works with adults as well as adolescents. And thank you, Dr. Israel, and thank you so much for joining us tonight for the podcast. So I know you have a very interesting career that started very early at a very famous hospital called Chestnut Lodge. So I just wanted to start with that. If you can tell us a little bit about how it was working there and your experiences that you wanted to share.
Well, it was a very intense and fascinating place to work. You know, I trained at Yale, and I did my last year at Yale Psychiatric Institute, which was also a long-term hospital, but based on treating people with psychodynamic psychotherapy. And so I sort of became interested in therapy from a very early age, because I think I used very interested in id, ego, superego, and the defense mechanisms, and I sort of used that as a way of dealing with my own anxiety. So it was something that I was sort of drawn to from a very early age and sort of pursued through my residency at Yale. The Chestnut Lodge, at the time I entered there, was actually at the center of a civil war in psychiatry. I remember I was sitting on at a table in the library in Chestnut Lodge, and there was there on the cover of the Green Journal was an article that said Asheroff versus Chestnut Lodge, sort of implications for psychiatry. And whereas up until then, psychiatry had been primarily psychodynamically oriented, this was the beginning of the empirical and biological revolution. And I felt it was trying for me, because I felt like here are what I had aspired to all my life had sort of come under attack and was no longer going to be, as sort of central to the field and as viable as I thought. So, I think that, but I do think that being at Chestnut Lodge, was a unique experience. It was like a concentrated laboratory of being able to sit with people with very severe pathology, and I think it gave us a window into really how the patient was experiencing the rest of the world, how patients were experiencing others. And the therapeutic process at Chestnut Lodge really involved, even though it was based on a sort of theoretical understanding of like object relationships and defense mechanism, you sort of had to act things out. You had to be there with the patient and sort of sit with the projections the patient put on you, and sort of, be an actor in the patient's mental life, sort of be like someone who represented what's going on in the patient's mental life, so that in looking at that and sort of having a patient, experience you different ways could sort of integrate and internalize you as a therapeutic, as a positive force in their own psyche. So I think that's sort of what it did for me. And I think in my future, as sort of being a more general psychiatrist, I was always able to take those that experience as a way of being able to understand what the patient was experiencing, what they could tolerate hearing, what they couldn't tolerate hearing, and also how they process their emotional experience, how they could communicate about their emotional experience.
Okay. Yeah, it seems like working with patients so closely for extended periods of time um, made you feel more connected to patients after in your private practice right now. Is it what you were trying to relate?
I think that's true. I think that when patients, I think even when you're a psychopharmacologist, which is essentially what I am now, the patient has certain transferences, they have certain expectations of you. They're sensitive to certain disappointments that are inevitable in the relationship. And I do think that in addition to into providing the medicine, by being there as they talk about when dealing with borderline personality, like a good enough good enough general psychiatric management as being like an effective treatment and I really think because it's because you're an object in the patient's life, and and having to deal with the inevitable ups and downs of the relationships, they and to have you be supportive of them, it it goes a long way to to helping them progress.
I think you mentioned the important factor of still being with the patient dynamically, even though you could just be managing the patient with medications, but things that we still say them therapeutically still matters for them, like long term. So I think it's still important to keep in mind, even though you're still treating patients with medications. Um, I would also wonder if you could share maybe like a patient or a mentor, someone who you probably had some powerful experiences there and something that really influenced you and you find to be memorable. If you don't mind, and if it does not break any confidentiality rules for you.
I think it's I had a lot of mentors there. I think I had really both at Yale and at Chestnut Lodge, because I think one of the advantages of it, you saw a patient 3 times a week in psychotherapy, and you presented cases. Everybody took turns presenting cases, and every case was supervised. I don't know that I had one specific mentor, but I think there people can, I was able to sort of take parts of what people gave me. Some people were very theoretical and could talk about things in terms of, what they're, how what the mechanisms going on, and some people would just listen and react, but some people also would. Would just sort of tell you what to do or tell you what they would do, or just by watching how they would react to things, you could sort of identify with that in your own mind and apply it. Um, so, I've had the thing about Chestnut Lodge is there were a number of, very intense experiences that were very, that it's sort of like a distillate of like years of experiencing, people with psychopathology, concentrated into a very short time. And, I think that, I think that, by dealing in that intense way with the patient's feelings and reactions, and also because they were very ill, the reactions tended to be extreme. It was helpful to, uh, it just you were immersed in it in a way that was sort of irreplaceable. You really lived the experience that they had. I've had a number of patients there who were and it really exerted like a real it really affected you. It's almost like the experience of being with someone that primitive is almost like an experience of merging in a way, because you're so intimately involved with them that you sort of feel what they feel, and they sort of make you feel what they want you to feel. So I had I had a number of I had a number of very intense experiences there. Like the bit, they also I learned how to deal with when things didn't go well. I had a patient who I was very, very close to there, which is sort of a funny thing to say about a patient, but I had a patient who was, very ill and sort of very, very self-destructive, and, like lived her life through suicidal fantasies. And I think that, she felt, she'd been through a number of traumas in her life, both in her childhood and in school. She was, she had somebody who she was idolizing, and then this person turned out to be commit a terrible crime. So there was tremendous illusion with it. And she was originally admitted to another hospital, after having tried to kill herself a number of times. And it came out, it came out in the therapy that, she had been the victim of abuse by her grandfather. And somehow, and she, had all these kind of, post-traumatic experiences. But in the midst of all this was, you know, a fascination with death. Death is a way of joining with her grandfather, and death is a way of sort of of experiencing a triumph over all the things that had gone wrong in her life. And as this sort of came out and it became more explicit, it was something that she could take distance from, and she was doing better, and was able to reflect on some of these issues. But but ultimately, in the midst of there was a suicide at Chestnut Lodge at the time, and shortly after that, she's intimated to me that she was feeling suicidal. And so I took her back, I took her from my office back to the unit and told the staff about it. But then in the seconds before the staff could implement, these, more monitoring, she hung herself, this, so it was a very, it was obviously a very intense experience for me, because it was early in my career, and I felt I was sort of beginning to, to achieve something, by going through this therapy, that I had, really, I worshipped over the years, this form of treatment. And then this happened, and I was, so I it was so it was awful at the time, but it was something that helped me learn a lot about myself and about my expectations of myself, and also just what happened, sort of experiencing the worst, which is what it was, makes gives you an idea what your limitations are, or what you can really accomplish and what you can't, but also makes it sort of easier to be with, at least more adept at sitting with people who have those kind of issues, in the future. So.
Well, thank you for sharing that experience, Dr. Israel. And it definitely sounded like for some could have been a career-changing experience, for some a life-changing experience, especially when you work with those patients that closely. I'm wondering if you had help from mentors who guided you through that experience, because it would be very difficult to process it on your own.
Well, I think everybody was pretty good about it when it happened, and I think that I had a supervisor at the time who was very, very, and he was able to sort of he was able to talk about what had gone on. And the other thing that happened at the time is we actually took it to I was with my colleague Wayne Fenton at the time, who also had a suicide. We went to New York to talk to two very two very accomplished suicide experts, and we went over the case. And the advantage of what I got out of that was that these people were really they were analysts, and they were able to really look at some of the factors involved in the case and look at the psychology involved in the case. And it was able to, by able to understand, I was able to understand what, how difficult it was to work with her, and how fragile her her attachment to the world was at the time, and that's what sort of made it more understandable to me. And it also, gave me a lot of insight into that whole, the whole realm of people who deal with suicidal issues. I think the one thing that it showed is that, some people sometimes, sometimes suicide is not only sort of a relief from a terrible reality, but there's also a lot of narcissism that's involved in it. It's a sense of, triumph or omnipotence, and sort of understanding that, and understanding that, you have to sort of work around that issue when you work with suicidal patients. So, yeah.
Well, thank you again for sharing that as a lesson for us, especially those who have never had to deal with it.
Mhm.
Probably some will eventually have to deal with it, and it's good to know what helped you. Maybe involving other people, having supervisors to help you process that, so that we can also learn from that. Um, Moving a little bit away from Chestnut Lodge, I know that after that you also transitioned into group practice and became a leader at the community hospital. Would you mind to tell us? I know you had a lot of challenges there as well. So tell us a little bit about that.
Leaving Chestnut Lodge, I was there for about 10 years, and then I left Chestnut Lodge to join a group practice. And it felt different, because to some extent, Chestnut Lodge at the time was, kind of, it was a luxury place. It was the Lexus of psychiatric institutions. And so it felt, so there was some sense, a different sense, in a sense where I sort of felt, when I was dealing with the group practice with people who really, who were just had regular insurance policies or on Medicare and Medicaid, and were trying to, doing their best to get through the day, and we're out in the world doing something. And there was also a good sort of a good feeling about, uh, at the time, Chestnut Lodge was the whole model was changed. And people would stay at Chestnut Lodge for years, and insurance would pay for it. They pay out of pocket if they were very wealthy, and but there was the advent of managed care, and that whole, the whole advent and sort of the redefinition of inpatient care, sort of, hit Chestnut Lodge hard, and ultimately, resulted in it closing. So I sort of like the idea of working someplace and doing the kind of work that society would pay for, but it was. It was a short-lived time at the group practice. I mean, I think, when you're out in the world, you deal with, and you're working in a group where there are, other people in charge. It was sort of, it's a mixed bag. It was a mixed bag for me. And I think that, you really have to worry about, the business and the collections in this place. They tried to expand, and the billing didn't get done right, so it hit financial problems. So I was able to escape from that, fortunately, after a few years, and go into my own practice. But when I worked for the group practice, I was introduced to the community hospitals. And I worked at a freestanding community hospital for a while, and then I worked at a suburban hospital, which is a general hospital in Bethesda. And it was a real change for me, because I'd been to a place where, where the lengths of stay were a year or more, and I worked in these settings where they wanted to get people out in days, or at most a week or so. So that was a bit of an awakening. And the endpoints were different. At Chestnut Lodge, the endpoint was, fundamental personality change. And, in the outside world, the endpoint was, symptoms getting better and not wanting to kill yourself, at least, or saying you didn't want to kill yourself. So, so it was different like that. But I was fortunate that it introduced me to that element, that kind of practice, that kind of environment.
And it was very different from what you were more used to as well. So it kind of expanded your experiences as a psychiatrist as well.
Right.
I think you mentioned something very interesting when we had our small chat before the podcast, that running and being in a leadership position is same as having a lot of children or having a lot of patients? I think that really struck me.
So unfortunately, I've worked many of the people in the room are people I've worked with. I don't want to tip my hand when it comes to this, but I think that I think that you're in a position where when you're a medical director, you're in a position of authority, and I think that the hospital where I worked as medical director was a community hospital, which is and freestanding psychiatric hospitals have sort of it's a no-win situation, because on the one hand the reimbursement's low, they keep they keep trying to keep the length of stay low, and there's not a lot of profit in it. So the margin is the profit margin is very low, and as a result, they're always on a shoestring budget. So it has a lot of ramifications about for the system, because it's unless if it's you need to be able to pay people to retain the people who are high quality and sort of progress to the point where they can be leaders within the system. And if you can't do that, they go someplace else. So that you really you don't have the staffing level, and you don't have the expertise to really impart necessary knowledge to the less experienced members of the staff. So it's always so it's always a struggle. So I think in that kind of setting, people go crazy. It's not, I'm exaggerating a little bit, but I think that it's very high stress, and things are suboptimal, and things happen that people don't want to happen. And, so you have to be, so as the medical director, you have to contain a lot of that, and know what's sort of driving people to do the things they do. So in that sense, you have to treat them, you have to think of them as patients, because you have to always know what's on their mind and what it would take to to help them through it.
Yeah. I still hear your kind of like psychodynamic approach to still feeling how the other person is feeling and seeing the world being integrated as a leader too.
Yeah, you have to try. Yeah, you have to do that. But yeah.
And regarding WPS, I know you also had a leadership position at WPS. Would you mind to tell us a little bit about that position?
Well, I was what was I going to say? Well, I started out as on the board at WPS, and essentially what happened is I was working at the hospital, and I thought, and I saw I was opening WPS newsletter, and I saw that I saw the elections for board members was taking place. So I thought that maybe because I'd been through as much as I'd been through, much of which some of which I told you tonight, that maybe the board would benefit from from my perspective. So. So that's where I started on it. And what happened, what ultimately made me president, was I was on the board for a while, and then I became treasurer for a while. And then unfortunately, the WPS, encountered some kind of financial problems at the time, which ultimately fell on my lap as a treasurer. And so I was, so it was my charge to go to go fix, go into the books and see what was going on. And ultimately, fortunately, we were able to get out of it. But so after I was treasurer, because I had that experience with the finances and things like that, I became president. So, I think that. I think that WPS is, my goal in being president of WPS is to make it as relevant and to the members as possible, and sort of, deal more with, issues of direct relevance to the practicing psychiatrists. And I think so, it was a start then. We've been through some difficult times. So I think what I accomplished was sort of, I like to think that what I accomplished was at least putting in the germ of a recovery from where we had been. And and I think my biggest one, I think, was to establish the legislative advocacy committee, and which is started off small, but now is getting bigger and bigger, and involved in all really involved in the Virginia, the district in Maryland. We have a partnership with the Maryland Psychiatric Society. We've members have provided testimony to the legislature, and we even worked on a prior authorization bill to restrict prior authorization that passed in some form in Maryland, and the germ of that was a collaboration between us and Maryland Psychiatric Society.
Well, thank you for sharing such an extensive and interesting experience, starting from Chestnut Lodge to being a leader and have to figure out the managerial part of the hospitals to WPS and having a private practice right now. That is very amazing, and thank you again.
Sure.
I would love to invite other members who are attending currently to ask questions. If anyone, yes, Dr. Welkman. Welkman.
Yeah, thanks. Thanks so much. I really enjoyed that, Steve, as you can imagine. Just a couple of stories. The WPS years ago used to host an annual joint meeting with the Washington Psychoanalytic Society, and I was head of the program committee of the Psychoanalytic Society. So we did that once or twice when I was involved with it. And then the WPS let us know that they no longer wanted to do that. And I found out why. It was a typo. This was back when we didn't do our own typing, and the secretary sent in the wrong title for the proposed joint meeting, the psychotherapeutic treatment of a manic depressive patient without lithium. It was supposed to be with. And so our colleagues in the WPS thought we were losing our minds, even more behind the times than they thought. It would really be great if I could have my camera. Anyway, I'll have to do a word picture of it. This is a book that has a chapter about the Ostroff case, which you mentioned, Steve, a New Yorker staff writer. Okay, I can hold up the book now. Thank you. This is the book, Strangers to Ourselves by Rachel Aviv. And the subtitle is Unsettled Minds and the Stories That Make Us. So she interviewed both me and Chris Keats for the chapter. And I was really pleased and shocked when I read it, because the gist of it was she was very, very sympathetic to Chestnut Lodge, but she did enormous research about the man Ostroff who brought the Ostroff lawsuit. And did you realize this, Steve, that he later sought more treatment from a psychoanalyst after he left the lodge and sued the lodge? That was ironic, right? And she interviewed his children. I think he had passed away by then, but they said that he got kind of obsessed with his lawsuit, and they had him come visit when he had new grandchildren. And all he wanted to talk about was the lawsuit, not really talk about the children.
Yes, I would call that Italianic impulse, that the guy, he really had it in for the lodge. But, it's interesting, the whole website that I think that he put together with, with primary source material about that case. So he was, there are a lot of elements to that. I mean, it speaks to having a broad, theoretical perspective, because it wasn't only biological.
Yeah.
Yeah.
That's
Yeah.
so true. That's so true.
Yeah. But yeah.
Good to share those memories of the lodge. Other people have comments.
Yeah.
Thank you.
You, Dr. Welgeman. Dr. Frank?
Yeah, if you want to turn my video on, I'm here. Hi, Steve.
Actually,
I have a couple of thoughts that I wanted to share with you. Not so much a question, but because you're a resident, you clearly are curious about the history of psychiatry. And I lived through much of the same history as Steve, only on a parallel track, because he went towards the psychoanalytic group and I went towards the medication management group when we were both contemporaries at Yale. But one of the things that I have come to appreciate is that long-term relationships substitute tremendously for deep relationships. That although consider myself somewhat of a psychopharmacologist, all my patients take medication, or almost all of them do, or they seem to want it. I've seen people now for 5, 10, 15, a few people even longer than that. And over time, just like you say, I'm a part of their lives and I feel close to them. And so I think we do ourselves a disservice if we forget the sort of human dimension of what we do, no matter how we do it. There's a huge humanistic element that is open to all of us if we, under the right circumstances. There's a lot of the history of Chestnut Lodge, actually. I've just written this book on a rewritten Persuasion and Healing. I don't know if you know that, Steve, but I have. And there's a lot in there. There's stuff in there about the Chestnut Lodge case, but also I lived through, there's a number of things about Chestnut Lodge and the equivalent units at Yale that I think worth mentioning. I mean, Wayne Fenton, was murdered by a patient and Chestnut Lodge and the kind of regression that goes along with that sort of environment was very destructive at the VA, where we had very sick patients being treated with, psychoanalytic theory alone. But on the other hand, if you combine psychotherapeutic understanding or decoding people's symbolic lives with medication, I think there's a huge amount to be done there that, we've lost sight of in a way. And perhaps you, right, Dr. Mikadze, will have the chance to rectify that again. The other thing is that you should know that one of the famous psychiatrists at Chestnut Lodge was Frieda von Reichmann, and she treated Joanne Greenberg, who wrote I Never Promised You a Rose Garden. So that book is about her treatment at Chestnut Lodge, which was wildly successful from her point of view. So, it's a very complicated story.
Well, I think it's also a good idea to think about how one's biological illness affects one's ability, how one's object, world develops. I think that, my feeling is that in different kind of biological mood states, the people, that the personality is not all that static, that it tends to, that in a higher or a more dysphoric mood state, it might regress to, more primitive forms of defense. So anyway, I think,
Well, I think mental illnesses affect our relational capacities in profound ways.
Right.
But once you recognize that, then you're still dealing with a person who's, relating to you.
Right. The
Yeah.
question is how much of that can you use a theory to be deliberate, or how much of it just happens in the normal course of a relationship? That kind of thing.
I'm very anti-theory, so to me, but other people, there's lots of. I mean, there's actually, late in my life, I came into a different kind of theory called self-relation theory that I have found very helpful. And I also think the stuff about defenses that George Vaillant has done has been very, very helpful. So it's I pick and choose. That's not quite as, complete as psychoanalytic theory, but it's still theory that's in there.
Right.
I think right now, as Dr. Frank was alluding to, that combination of therapy and the medications that are available right now are a very effective combination, and hopefully it'll develop more and more as time goes. Dr. Mohiuddin?
Yeah, I wanted to thank you, Dr. Israel, for a wonderful presentation and what wonderful service you've done to WPS. But I was also curious, you're one of the few psychiatrists during COVID when nobody was doing injectable injections and people were desperate. all your different types of career has prepared you well to be an outpatient psychiatrist that just doesn't see worried well, to see actually real psychiatric patients. And I want to say, I mean, what would be your advice to future psychiatrists to be ready for that kind of a scenario when during COVID, I mean, I remember people couldn't get their injectables because everything was shut down. So just some advice from you about the new generation of psychiatrists coming on.
So, for all patients, you mean, or
I'm sorry?
I'm not sure what advice for?
For the new psychiatrists coming on to take on the working with chronically mentally ill patients, severe mental illness, and outpatient settings.
That's a good question. I think it's the way I'm sort of a unique person, and I'm I don't know if I'm the unique I am, but I know that I think it's very hard in private practice to deal with some of these patients. I think it's it's important to have a team, and I think that I found myself sometimes in my practice is I feel like sometimes I'm a little overwhelmed because I'm a solo practitioner. I'm dealing with patients who are very ill. So I don't know that I think it's hard. My practice is I take Medicare and Medicaid. I take all kinds of insurance, and I think that to do that and make a living, you have to have relatively short follow-up sessions, and so it can be overwhelming. Um, my advice is have a mix. I mean, that's what I do. I don't see exclusively very ill patients. I see a lot of very ill patients and some function and a lot of functioning patients. And I like I think what I get out of it is that I get surprised sometimes because some of the patients who are dysfunctional can be very intelligent and observant and almost poetic in how they describe themselves and others, and it's always it can be very enriching to do that. And I think that maybe my advice is when you're dealing with patients who are sick, and don't live for those moments when you find something very human and unique, and that expands and gives you an admiration for somebody living in difficult circumstances, but yet manages to do that, manages to to be to express some kind of humanity. So I don't know. I think it's a very difficult thing to do, and you have to be willing to at least get some sense of reward in working with difficult patients to sort of compensate you for how difficult it can be sometimes. Yeah.
Dr. Collins has another question.
Sure. I'd like to just make a brief comment and follow up on what Dr. Israel mentioned earlier. First of all, thank you, Steve, for a great presentation, and Miriam for a wonderful interview. And I think early on, Steve, you made a comment when you were talking about that patient who had a borderline personality structure they're working with at Chestnut Lodge, and talking about really essentially the transference, countertransference, interaction, and thinking about those in training and training to be future psychiatrist or psychiatrist in training. And, having worked at Chestnut Lodge myself, having been in protocols together with you as well in private practice and even WPS, I think it's so important. It's transference, countertransference is so ubiquitous that I think it's helpful for the residents to be aware that this is something that if they learn to understand transference, countertransference, and appreciate that the therapeutic alliance is so important, that no matter what they're doing in psychiatry, whether you're doing psychopharmacology, whether you're doing psychotherapy, whether you're on the CL service, even if you're in administrative psychiatry, how that is so relevant to your practice. Kind of universal, I think, really. And thank you. Anyway.
I mean, it's going to happen. You're right. It happens no matter what you're doing. It's going to happen, and to have a way to understand it, to have a way to recognize when what you're experiencing within yourself and your feelings to the patient, are the result of transference and countertransference. So I think it helps you metabolize, helps you not take it personally, and it helps you, yeah. And I think if you you know if you recognize it and you sit with it, it hopefully you become sort of the integrator. It all resides with you, and the patient's been able to experience you, in both both all good and all bad in the same person. It can be a very powerful thing for.
Absolutely. Thank you.
Thank you. We only have about a minute left, and I see Dr. Waugeman has his hands raised. If you have a quick question.
I'm so sorry. I just wanted to clarify, during the years that Steve and I were at Chestnut Lodge, everybody was on medication. There's a misconception that we never used it, but especially because of the Ashraf case. Yeah.
I think that, I thought one of the things that was good about, Yale is you had people who were sort of, it was sort of at the version, at the, sort of the boundary between the the psychodynamic and the biological. But I think a lot of people who were very serious about the psychodynamic were also very serious about the psychopharmacology, which made it and there was a certain, and I think that the same thing was sort of true at the lodge. I mean, there were some people who were very dogmatically, feeling that medicine was an intrusion on what was, like a pure process, but there are also a number of people who embraced both, and we were actually one of the first sites that did a phase 3 study on Clozaril.
Right. Yeah.
So that was a big thing, and then I think Wayne we also did one on risperidone. So we were. So we did that, and we were also fortunate because because it was a private sort of luxury Lexus institution, a lot of people had money to pay for consults from some of the experts down the street at NIH. So Bob Post was a regular presence there. Dick Wyatt, who's an expert on schizophrenia, was regularly there. So we were, so I, as being one of the people who prescribed medicine, really benefited. It was almost like having an apprenticeship with some of these great psychopharmacologists. So that was, so what Rick says is very true.
Thanks.
Well, thank you everyone who asked the questions, and thank you, Dr. Israel, for sharing such impressive insights into diverse experiences that you had throughout your life. We're coming, unfortunately, to the end of today's podcast. Our next podcast will be on February 26th, and our guest will be Dr. Mohiuddin. Thank you again for everyone who joined us tonight, and I hope you have a good day.